a minute. We're kicking off we're continuing, I should say, our language barriers and incarceration status end-to-end review. All right, and if you wanted, I'm glad you thought it was good, buddy. Sometimes all of you who attend this call know the nerdy levels of evidence that we go through in order to accept anything. So in our implementation affinity group meeting, we just presented that to somewhat of a different crowd on psychometrics. So it was a fun meeting. I think we're ready to kick off. It's 4:02, but we're almost there. Might as well we can go to the next slide because it's just the antitrust slide next. And actually it's the welcome slide, but I think it's already 4:03. So we can go back. I think, is this the next slide, Hamali? No, I think, so go to the second, there we go. Okay, start here. Thanks for joining. Folks are muted upon entry. All calls are recorded. The recording is available on the Gravity Confluence page after. Please send all chats to everyone. That way we can have an open communication and an open conversation. Next slide. It's important to note that as an open standards initiative, we are required to follow fully with federal and state antitrust laws. This includes both general, both specific guidance, but also just general construence. So adherence to antitrust guidelines really is important, and this includes avoiding any behavior that might be construed as an antitrust violation. Next slide. Our agenda today is to do some brief announcements. Some of them are repeated from the previous call, but then we're going to go over again the 2025 plan opportunities. And then we have the real meat of our meeting is continuing our language barriers end-to-end review and an incarceration status end-to-end review. So there's a few topics that we're working on, emerging concepts in incarceration status. We will sort by, I think by the end of the week is my hope. Because we need to go into, we have one more meeting of end-to-end review, and then we go into the formal vote on November 21st, and we're on target for that. We're grateful you all are here and have been part of this work as we've been developing it together. Next slide. Announcements. Next slide. There's nothing new here. So there's the brief moment for lingering comments on the utility and security IC10CM submission. Very grateful for all the conversations happening on our technical work stream. We're having a really wonderful conversation on use cases and looking forward to 2025. An implementation meeting. I should say next meeting is 2020 is November 21st, because the next meeting was already happened. It was just before this. But our next meeting is actually November 21st, and it's adjusted a week early because of the Thanksgiving holiday. Next slide. Again, we just mentioned this in the affinity meeting, but it's really important. So just a note that the Assistant Secretary for Technology Policy, ASTP, Health Information Technical Advisory Committee, HITAC has convened the Health Equity by Design Task Force. As some of you know, I have the honor of co-chairing the Health Information Technical Advisory Committee for ASTP. And, in my role there and role here, assisted with the design and development of the task force. There's links with to the task force webpage going in the chat. We want all of you who can to come, because you all are, very, very deep in the weeds regarding the charge of ASTP, which is data and technology and how it intersects with health equity. The purpose of the task force is to provide ASTP with recommendations on promising practices, challenges, and resources to support health and human services organizations to incorporate health equity by design principles into the design, build, implementation, and use and monitoring of health IT. You can find, again, everything that happens in the HITAC ecospace is public. So you can attend the meetings, and every single meeting there's a task force section, which is public can add comments, like through the chat, but then but the task force is leading the charge there, and then there's always an open public comment opportunity at the end. Those public comments become part of the documentation and public documentation of the meeting. So it's a great opportunity to come and have your voice be heard. And all are welcome to this critical public convening. Again, it's going to run from now through early spring of 2025. Next slide. Again, a Gravity Friends. So we have some Gravity Friends who participated in that as well. Again, our friend Mark Savage was one of the ASTP thought leaders in that space. Any questions on announcements? All right, next slide. So many of you know what Gravity is. I always need to say the slide. So Gravity is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. You all are Gravity. Next slide. Again, we are very grateful for our 2024 members and sponsors. We have some new sponsors coming in 2025. Super grateful for that too. And again, as always mentioning, from a social justice framework, we are unique in our governance in that we center designated voices who are at the front lines of social care practice to ensure our governance includes their expert perspective. Very, very grateful for our designated friends. Next slide. All right, this is the roadmap. It has not changed. We really need to, we'll get a 2025 roadmap up shortly. We do have a clear plan of what's happening within terminology, and that's on the next slide. We have one more affinity group meeting. We're working right now on the technical work stream on the ballot to align with the US Core. And then we're thinking forward into 2025 and beyond with our use cases. We are going to present on some findings from our discovery in an upcoming technical call as well. So that payment and reporting discovery is coming to you soon in a technical meeting. Again, trying to make all the things that we do in this very complex roadmap transparent and accessible to all of our community members. Next slide. And again, so social care voice co-design, this was our work last summer. I'm going to probably sunset this slide in particular, but what we realized is that we weren't correctly highlighting how social care co-design activities were centered in our 2024 planning and 2025 planning. So we are trying to do a better job of that. So I'm bringing in those little pearl icons of the use cases, the co-design element of work elevated whenever we're talking about future and current work. Thank you. I think I might be a little talked out, but I'm going to try. Next slide. All right, so 2025, as you are aware, we are working on person-level discrimination. Again, this is building from a submission that AMA had for an ICD-10 code for racism. We long have had addressing person-level discrimination on our roadmap as well. It goes back 2 years. We are thinking large and including all different types of discrimination in our perspective to think comprehensively, because we cannot think of person-level discrimination without thinking about chronic stress and the effects on health. We're coupling our work on person-level discrimination with concepts in minority strain and weathering, toxic stress, and adverse child experiences. Yes, gender-based discrimination is included there as well. Yeah, I didn't include all the et ceteras, but absolutely. Because transphobia is a subtype of gender-based discrimination. I didn't include all the different subtypes, but 100%. All right. I hope, Tom, that answered your question. And then fall 2025 is food access and neighborhood safety. Because of the critical importance of the spring 2025 domains, akin to our work in incarceration status, actually, and language access, we are meeting early with subject matter experts in the field to really try to make sure that the work in the spring is designed well and is authentically led and guided, and very grateful for all of the experts who are helping us in that work. We also are going to be continuing our work on enhancements. Coding for Food continues in 2025. And continuing our work and analyzing gaps and opportunities within housing instability and homelessness, supported by our friends at CDC. Still trying to advocate for the critical work on protective factors, like ethically. I'm going to say it very plainly. It's very difficult to talk about chronic stress without talking about protective factors. Working on protective factors is our primary intervention when it comes to addressing the burden of chronic stress. In addition to addressing the stressor or the stressing agent, it's critical in the work of Administration of Children and Families. Really hoping we get to work on protective factors in 2025. If I have a North Star right now, it's ensuring that we address that in time, and then also trying to support aggregate reporting. You can see that these are the topics that are directly aligned with co-design and the use cases that are applied there. Next slide. Okay, so we are in our second to last end-to-end review meeting. And again, there's some changes today, not a ton. We have most of our concepts detailed. We have some existing critical work to do in incarceration status for consensus work there. But we are doing really well, friends. Very grateful for all your engagement. We have end-to-end review today, and then in 2 weeks, and then we go into the vote on November 21st. Next slide. Our principals constantly present. I want to note that I had an opportunity to present. I don't know if I see my friend Sue Bowman on the call today, but Sue Bowman is a friend from American Health Information Management Association, AHIMA. I had the honor of presenting with her at the AHIMA conference in Salt Lake City on Monday. I'm Tucker because I just did 2 red eyes out there to do that. But she did a really brilliant job in talking about our principles and how we use them. And so I'm really grateful for our members and our community members and their collective expertise. So Sue was my co-presenter, and it was by far the best presentation on gravity I've ever been part of. And it was largely because she did a much better job than I ever do. So Sue, if you're out there, just know we appreciate you. Next slide. Okay, and here we're going to go into the work. Next slide. And again, we have, just making sure we have Kwesi on the call. And then I don't see any other subject matter experts on the call. So again, there's not a ton of changes, but I try to represent when we don't have other SMEs on there, but Kwesi is in the car, and I'll try to be careful and respectful of you. I know you don't have to be on camera, friend. Just speak, it's fine.
I'm gonna pull over shortly to be present.
Okay, so language access is first anyway, so you have some time, friend. Just a note that we are working, as I mentioned, with CDC on a gap analysis to support housing instability and homelessness. Any new concepts that are aligned with that work are highlighted in purple on our slides. Next slide. And you can find the masters, as always, now on Tuesdays by 5 p.m. Pacific time, posted on the Confluence in the following areas. Coding for Food is under Food Insecurity, and then language barriers and incarceration status for this domain, for this meeting, are in their own domains and domain pages of reference. Next slide. What do we do in end-to-end review? What we do is we step back and then consider the whole set and ask questions of it. We ask if there's missing concepts. And again, I just met with one of our language access SMEs today, Lisa Bothwell, and we identified a possible missing concept. So coming to the language access SME meeting tomorrow. And then, are there incorrect concepts that need to be changed? We work on that as well, or refined, or nuanced. Are there concepts that are unnecessary and should be removed? These are all questions we ask of the set. And this time it becomes pretty formal. And so comments and edits have to be offered in written form with rationale and evidence for suggested alternate approaches. Because we've come a long way together. And so if there's something that needs to be changed, we do need to support the consensus we've already found, because everything we've created has been created in community. And so if something needs to be changed, we need to present it formally and then bring it back to the community to resolve. And again, including our subject matter experts. So anything you put in here is analyzed with the subject matter experts and then brought to the community formally. Next slide. You do it by email. Next slide. All right, so we don't have a ton of updates. Again, thank you to our SMEs. I just want to give a shout out to our amazing subject matter experts who have assisted. Marsha's been on sabbatical in Europe, and she's been coming in from Europe. Our amazing friends at the CDC and CMS, just a pleasure. Authors of like the standards for, medical interpretation and certification, or the class standards that guide, the appropriate care in language access world. These are our SMEs, and we're incredibly grateful. It's been an honor and pleasure to work with them. Again, very, very grateful to our friend Lisa, who's been coming in from a disability justice perspective from ACL, and her as an ASL speaker herself. Very, very grateful. Next slide. So we had to think a little bit differently when it came to this domain. I presented this last week. I'm going to ground it in again because it's really important. One of the things we've been thinking about when it comes to this domain is, what is the problem and whose responsibility is it, right? And so our perspective and our approach at Gravity is to identify needs and intervene on those needs. And so when we thought, even though we introduced all kinds of concepts in the beginning, such as primary language, et cetera, when it comes down to identifying the needs, the need really is regarding whether we need to lean into a language discordance between the person and the setting. And so really leaning into those limited English proficiency concepts, interpreter needed concepts, and translation concepts, and then ensuring that our goals align with that being met. Again, the organization or system's responsibility is, again, to meet the person and their needs. I want to note, and we talk about this a lot in our SME meetings, because of different legal requirements regarding disability, there are different requirements for meeting entities with speaking ASL than other languages, and we talk about that a fair bit. And we're going to go into the concepts, and there's been some slight tweaks over the next slides. Next slide. Next slide. So our diagnostic concepts we're resting on, there's been some changes here. One of the things this means, again, end-to-end review is it necessary? We ask, ourselves. And so we sat really carefully with the use cases within healthcare settings to support assessment of English proficiency. It is very, very clear that the spoken English proficiency concept is necessary, universal agreement on that, very, very clear agreement on what it means to need help, which is anything less than very well. And then limited reading and English proficiency from a translation perspective is important as well. So if your discharge instructions or your medication instructions are not in a language the person speaks very well, that is a language discordance and an opportunity for inequity. Even though some of our surveys assess written English proficiency, our subject matter experts, when we thought about it, did not feel it was actually a requirement at this time. Not that it can't be introduced later, but they're already adding reading. We identify that spoken is the primary one, and so they elected to hold written English proficiency at this time. And whenever a use case demonstrates that it's necessary, we can add it. But that was their perspective. And we walked through all of the healthcare use cases and spent some time on this. And it's, they were fairly consistent that from a supporting the ecosystem perspective and leaning into what's needed, the spoken and reading are the two primary ones. And we're even having conversations on how to operationalize the limited reading English proficiency concept. But again, that was the decision of the SMEs. Again, a slight subtle change since the last time we presented it, very much aligned with what we do in end-to-end review. Next slide. What I neglected when I made the slides to include the very, very important concept of preferred language, which is a problem. So thank you, Hamali and Sarah, for catching that. So the update here is that we added the preferred language concept. And this is the language one wishes to use when discussing health and healthcare. And so that is a concept we're definitely leaning into. Hi, Lucy. Yes.
Yeah, language one wishes to use refers to the patient. What about to be used when referring to the system dealing with the patient? Does that belong here? Is that implicit?
Oh, that's good. Yeah, that's a good consideration. I will bring that back to our SMEs for tomorrow. Thank you.
Thank you.
Yeah, because that puts the onus on the person. Certainly the definitions we have, our definitions and references all focus on the person, so we might not be able to change it. Like Joint Commission has the most extensive publication on this concept, and there's a ton of materials on there. But I really appreciate you highlighting that. And if it seems, we'll bring it back to the SMEs and analyze our existing references and see.
I definitely agree with patient-centeredness radiating from this formulation, but when dealing with language that one wants to use, the system has to react, or we would like to, I should say, we would like systems to react. And so if we put it in the definition that shows how deeply we're thinking about system responsibility being patient-centered.
One of the things we can imagine, Lucy, is leaving this part intact and just adding a second phrase. And thus the language the health system should use to meet the person, right? And so,
Great.
yeah.
Yes, fine. However.
Yeah, because then you still align with the Joint Commission references, but you were clearly stating our claim that this is a language a person wishes to use when discussing healthcare, and therefore the language the system should use to meet the person, right?
Right.
So, we'll bring that back. And then Rita, I see a question on, so we do not, and I know I just want to note the emerging demo project, our friends at Civitas and AHIP, had that initiative. So right now we do not have a difference between preferred spoken and preferred written, because almost all of the regulations speak to preferred to the spoken. But thank you for that. I hope that answers your question. Well, I can bring that back to the SMEs as well. We've talked about that when we did raise the demo approach in the last few meetings. We took it out this time, but I hope that answers your question. Okay. Next slide. And then we have some additions, again, directed by our language access SME, our ASL representative from ACL. She edited and asked us to edit our American Sign Language interpreter needed to be inclusive, because of course we don't want to exclude other signed languages. And even in the US, there's multiple signed languages. So we are going to be, we changed our request. I changed our concept of American Sign Language interpreter needed just to sign language interpreter needed. I do want to note that one of the things we'll be talking about tomorrow is the lack of granularity in ICD to represent this concept. So this concept of interpreter needed gets rolled up into a very, very fluffy, Z code that does not distinguish interpreter needed at all. It's I'm trying to remember what it is, and so Kamali can probably remember because she probably has access to this master list. But Lisa wants us to explore, and we're going to explore tomorrow, whether our clear delineation of interpreter needed warrants an addition of an ICD concept to support that. And so that is our topic for tomorrow's meeting with our subject matter experts, because right now it, along with a host of other things, map to an incredibly non-specific vague Z code. Again, you can see that Z code in our master list. It was posted on, it's part of the repertoire, but we're going to examine whether it's specific enough. Do we know? I do. So Tom, I will investigate that. Unfortunately, Lisa's not on the call, but thank you for that question. Is learning sign language skills going to? Yeah, so I know Carmela's so Tom, do you mean USCDI is what Carmela is asking? Because I didn't want to get into that. Carmela's on the call though. Hi, Carmela.
Hi.
Just hi. Yeah, so Tom, do you mean USCDI? Oh, yeah, yes, typo from, so you mean in its language sets? I think it does. Correct? Carmela, correct me if I'm wrong.
Yeah, I was asking about the signed languages in the language set.
Yeah, I'm fairly.
So USCDI doesn't specify that, but I will go check while you move on. I'll put it in the chat. I'll check the terminology binding and the spec, and I'll just look in that value set and see if sign language is in there.
Thank you.
I do want to note, and this was a very just another opportunity. because some of the primary language is what you're referring to. Well, preferred language and primary language are both in there, but one of the things we noted today when I was meeting with Lisa is a very, very poor representation of sign languages in SNOMED, even though main spoken language is well represented in many different subtypes. So I'm going to just state that there are opportunities for being inclusive of different sign languages across terminology standards in general. And I have yet to ask our amazing friends in the terminology team to do a deep dive, because I've been in meetings since 1 o'clock. I met with Lisa at 1, but then I'm going to guess that there's definitely an opportunity to include it in different value sets. I do want to note that Lisa Bothwell, one of our SME who's assisting us in this, also advises the American Community Survey and U.S. Census on appropriate inclusion of sign languages as part of their language spoken at home answer list, which is a driver for standards in nationwide. Lucy?
Sarah, you may be getting to this, but I'm wondering if this entire domain addresses location of language assistant. Is it okay to be remote?
Oh, yeah.
Does it have to be there for telehealth? Is it better to be there in person because people read body language? I'm wondering how the location of the assistance figures into, shall we say, the quality of the assistance.
We have talked extensively about that. Again, how it's operationalized is a little bit outside of scope, but we do talk a lot about what statements of needs in person. We have like an in the hopper, actually, needs in person, like translation. So there's more to come on that. We have definitely discussed that in our subject matter experts meetings about trying to elevate when tele interpretation is not enough, understanding that in rural Vermont, we are primarily tele-based, but we do try to get in-person translation when we can. But yes, Lucy, we've talked about this. More to come on that, and our subject matter experts who are continuing to lean on that in the Friday call. It's like one of those like gaps, like how do we address it? It is definitely also something, Lucy, that's included in our goal statements, which we'll talk about very shortly, because there's a couple components of the goal statements that include meeting the person and the method as well. I hope that makes sense.
Well, I think we need to anticipate this because there's no question in my mind that AI is coming here and that systems will subscribe to some allegedly effective and
Oh, yeah. So
efficient and all of that instead of people being involved
yeah. So there is a
somewhere.
so hold goals. The goals are coming in.
Okay, thank
Yes.
you.
Okay. Yes, an ADA. Yes, I did mention Janice. ADA requirements are for sign language 100%. And then Carmela's researching data bindings. I talked about SNOMED gaps. More to come there. Okay. And then Hamali, thank you. This is the very, very fluffy Z code that all of our interpreter needed concepts map to currently, and any incoming ones will map to persons encountering health services and other specified circumstances. It is not specific at all. And so tomorrow, the main topic of the day is to lean into whether we want to submit for an interpreter needed ICD code. Lisa and I were talking about the pros and cons of that this morning and looking forward to bringing it to the SMEs tomorrow. Okay, next slide. Whew. I need a cough drop, I think. We will not be defining primary language. And that's an important thing to say, because when we sat back, we just realized it was a bit out of scope. Again, it's not a problem statement. It doesn't require intervention. And because our work centers on health equity, and within this charge, we delineated preferred language from primary language to identify opportunities for care, right? And so the language you speak or the first language you learned or any of those primary language concepts is not one of those concepts of reference. And also, we just want to note the existing definitions for primary language are just all over the place. And so when you do a lit search, it is the language. Sometimes it's conflated with preferred language, which is what we ventured to separate, right? Preferred language is the language which is used to discuss your care and healthcare. Primary language is something different. And that's actually very well detailed in the Joint Commission references we're using for preferred language. And the class standards speak to that as well. But existing definitions for primary language, including everything from language spoken at home, which is how the US Census assesses it, language learned first, language spoken most, and language in which a person is most fluent, right? So these are all primary language concepts, again, outside of our scope, not something we had to lean into. We leaned into preferred language and interpreter needed and translation needed concepts. But just a note, you won't see it on the masters because it's not something that's easy to define. And we figure bigger people than us can work on that in time. I love that, Tom. That's really nice, Tom. All right, next slide. All right. Yeah, so that's, Rita, if you go back, I'm sorry, one slide. So native language is a concept very clearly of what you learned first, right? But that's only one methodology, right? And what you learned first is not necessarily the language you speak at home, according to, which is what the method of the US Census is. And neither with the language you speak at home, nor the language you learn first is necessarily the language you speak the most, nor the language in which you're most fluent, right? So this is why it's just all over the map, and we were just like stepping carefully away. Next slide. All right, now we're going to assessment instruments, a few updates, mostly some errors that I made that Hamali and Sarah helped me correct. Next slide. Again, so preferred language are instruments that ask about preferred language for communication within the healthcare setting. There's a lot of opportunities to improve all of these instruments. And we mentioned some existing work in the ecosystem to do that. Our SMEs, again, are walking out of here with all kinds of ideas about instruments they want to craft. And we know that our friends over, like I mentioned, Civitas, AHIP, and HL7 are doing the demo work, which is a payer-focused instrument development, but more to come. But of what exists out there is what and is implemented is what we present today. So right now, the best in class preferred language concept we have is the SAMHSA core set, which is what language do you feel most comfortable speaking with your doctor or nurse. It's not inclusive of different healthcare types. We know this, and we hope we know that there's better questions coming in time, and the moment they're added and our SMEs approve them, they will be part of our sets. Next slide. And then the interpreter key concept needed. This is a little bit of a better version, but it's the best version we have is the inpatient rehabilitation facility patient assessment instrument concept. For you, do you want or need or want an interpreter to communicate with a doctor or healthcare staff? Again, lots of opportunities for improving these questions. Our SMEs are leaning into it. But this was the best version that we had of the interpreter needed concept. Again, another simple way of demonstrating interpreter needed can come from utilizing iSpeak cards and things like that. Next slide. So instruments for English language proficiency, the best in class is the gold standard methodology of the US Census Bureau. And so on the next slides, we'll focus on the self-administered versions, not the asked versions. Next slide. So there's an update here. I incorrectly, even though the question's the same, the answer list from the American Community Survey, which our SMEs have been very, very careful to center, is not the same answer list as the National Latino and Asian American Study. And so what I had in the slide before is the question that's the same, but the answer list was saying that it was from the National Latino and Asian American Study, but it was actually the US Census answer list. Again, what you see for the question and answer has not changed. It's just getting correctly attributed to the American Community Survey. And we got authorization from the US Census Bureau to mention it this way, even though the administered version is on the US Census that's in the open version. This like changing pronouns is within 100% within the tested psychometric valid method of the US Census Bureau. And they do have a version that mentions just this in the computer completed version someone can do at home. So just know we changed the attribution to ACS, which is appropriate.
Sarah, you have a contact in the Census Bureau? That is really impressive. I'm sure that was not easy.
Oh yeah, we don't, but they reply it was not easy to get, But now that we have it, they are so quick on the draw. I mean, I think I sent an email and they replied within 15 minutes. It was amazing.
Congratulations. Okay.
Yes, I know. We're very grateful for our friends. So this is one of the, they do know that we care deeply about correctly representing the methodology of the ACS, because the important thing about ACS is it's the methodology that's borrowed across almost like a ton of population health, federal like instruments and assessments, like longitudinal surveys of wellness. So the methodology of the ACS is really, really significant. And so they know that about us, that we care about them. Next slide. Okay, so this one is again, you can see how well do you write is no longer centered because they decided they're going to hold on that. The correct answers for the National Latino and Asian American Study for all of its questions are poor, fair, good, excellent, don't know, and refused. Again, this is a very, very prominent study. It's nationally implemented. It's been creating excellent data for a very long time. Because the U.S. Census Bureau answered list is the gold standard, this instrument's not accepted for the spoken English concept because the Census Bureau rules very clearly with our SMEs. Thank you, Carmela, for the follow-up. And thank you, Lisa Nelson, for being an amazing advocate for social determinants of health. And Carmela says that we're going to follow up. Go team. And Carmela, we have contacts at ACL who can help there. Our SME is a federal SME from Administration of Community Living. Go team. And so the answer list for National Latino and Asian American Study is here: poor, fair, good, excellent, don't know, and refused. Tom, and I hope you see your question. And Carmela, you're amazing and we love you. All right, next slide. Okay, so even though we're not creating definitions for primary language, we do want to elevate the best-in-class methods of assessing the instruments individuals speak. And it really is always assessing in the individual's spoken language. So asking a person in English whether they need an interpreter is problematic. So assessing an individual's primary language is always done best in primary language. And you can see this is the way the USDA prefaces the current population survey, which is the way they assess food insecurity. It's these I speak statements. And the US Census Bureau does the same thing. And most federal approaches do that as well. So they always ensure that you are asking the person's primary language before you enter into any assessment. Next slide. And then you can see other I speak methods on the next slides here. So you can see we are really working to curate Indigenous language in I speak approaches, and we've learned a lot about that as well. So I have sent information off to my friends at USDA who validate and authorize the food security module regarding updates with Indigenous language options and their I speak. And we said the same thing to my friend George Carter from HUD. So Gravity also has friends with the authors, has longstanding relationships with the authors of the federal instruments for USDA and HUD. And so there was a little private ping I sent regarding Indigenous language representation in I speak cards, and they received it, and we're grateful. Next slide. Whew. Okay. So we did talk about understanding, and we did, it's one of the things we assessed, Rita, in previous slides, and then it's very, very complicated, very important, but very complicated. So the SMEs are really focused on speaking and reading at this time. We had a lot of conversations about understanding and speaking and reading and crisis in our internal meetings, because the language in which you're able to speak depends on what you're talking about. And so we did not, there were understanding questions as part of our assessments. We just didn't elevate them. Lucy? Whew.
Sarah, Rita's question in the chat leads me to wonder about age and how all of these language standards I'm going to say, forgive this assumption, applies to anyone over 18. What if the patient is 9 or 5 or I don't know?
So you, certainly the moment,
If you're 5 years old, your language understanding in your primary language is limited by being 5 years old. And so a pediatrician is talking to you, they obviously are aware of that. So I'm grappling for how to understand how the concept of understanding applies within age cohorts.
we did have a lot of talk about that internally.
Okay,
And
great.
how it also relates to literacy and then cognitive impairments and all kinds of other things. And so just know we're leaning into what seemed most appropriate for this use case, but there's been some pretty robust conversations internally with our SMEs. Yes, I don't know. I don't want to talk about it too much now, but happy to talk about it.
But maybe in the final product, if we're talking about, if we're assuming adults, we should say so. And if we're not assuming adults and we have something to say about the population from 0 to death, we should say that too.
You're not assuming adults, no, because
Okay,
first of all, like the moment an individual can communicate, you can ask them you can assess what language they desire to communicate in. Most of our methods also allow there to be proxy representation. This is part of the pronoun fluidity with the US Census Bureau approaches. So certainly we don't intend this to be just an adult assessment, even though the subtleties of how one assesses language proficiency from interpreter needed in any instance where the individual is not able to fully report for themselves is complicated. But we do not intend it to just be adult based.
thank you.
Quick addition to that, are any of these codes meant to be applied to like family members that the patient wants to act as their interpreter, right? Because there may be questions of even if the family member is old enough, there may be questions as to whether the family member can adequately interpret, like has the medical literacy, maybe they speak English well, but I don't know. I guess again, that's a description of the family member. It's not a description of necessarily of the patient themselves. Does that make sense?
It does. And now remember, this domain came out of our work on health literacy. We recognize them as separate but interconnecting concepts. Our SMEs are very careful to state that it's not best in practice to have family members interpret for family members. But those are all variables we discuss in our internal call, but the idea is to assess the needs of the person. And certainly all English language proficiency is ideally self-reported. And we're going to get into we're on the goals page, Matt. You really so we're going to get into what qualified interpretation is aspirationally on this next slide. I hope I'm not brushing over your question, but
No,
again,
no.
okay, next slide. We're going to go and again, we have qualified here, but there are very clear standards, and I mean like regulatory standards. Whether they be Joint Commission standards or federal standards in the class certification for what these concepts mean. So the high level goal, we find they're presenting the definition as defined within the class standards is the success. Well, this is a long goal, but it's the definition, not the concept. Is the successful joint establishment of meaning wherein patients and healthcare providers exchange information, enabling patients to participate actively in their care from admission through discharge, and ensuring that the responsibilities of both patients and providers are understood. This is like a long, but this is 100% from reg. Boop, pulled, blocked, right? So that is the meta goal of what we're looking toward. And Lucy just addresses some of the things you were raising as well. And so we've talked with AI has been raised a lot at here, but just noting that this aspirational goal, like it does kind of put some boundaries. The next one does as well. So we have 2 additional goals. We presented them last time. We're leaning into them again, which is receives consistent qualified interpretation and preferred language for healthcare. what qualified means is also fairly clearly detailed in statute and regulation, and so we have that as a backup. We can share the definition for qualified after the call because it was just the definition for qualified. We did not put it here, but that would again put very clear bounds again around what type of interpretation meets the standard for the standard. Again, raising AI options, whether or not it would qualify as qualified to be to protect it, like it likely would not. But again, effective communication and the qualified nature of interpretation are aspirational goals. And then timely interpretation is a separate concept that entities are measured against, and so that's held out independently. And then consistent is another one. Lucy?
Sarah, given that effective communication definition is in regulation, I'm still going to react to this adverb in the last line, responsibly. Who, responsibly is in the eyes of the beholder. So, okay.
Got it. Luckily, I can take it back to the mount. Thank you.
Oh. So what whose regulation is this? Can you tell us?
This is directly from the class standards, right? Hawali and Sarah. I'll pull the citation.
Yeah,
Thank you.
maybe a better adverb would be actively in there.
We will share the citation.
Yeah, but the citations are always on again, we don't put all the citations here, but they're always in the background of the master.
And just not having an adverb at all would eliminate the next 30 minutes of what's the right thing to say here. Just enables them to participate, period.
Thank you. Okay, Denise? Again, I want to make sure we get incarceration status soon, yeah?
No, I'm just, we have to go there in WIC because the kids have to come in a lot of time. So you went to the USDA for all that because they have it spelled out what we're supposed to do too, right? Okay, if not.
Oh yeah, we have the USDA citations, 100%, yes.
Okay, just wanted to say that. Okay, I couldn't type it right. Okay, thank you.
So Hamali's putting in all the, Holly's putting in the links. Whew, I've been talking too much today. I have to even use a cough drop. Okay, so the Joint Commission regs were put in there, that we have the class standards as defined, and I think they're now there as well, and collectively they form our backbone. But thank you. We have, again, luckily I will communicate your the responsibly component. Okay, next slide. I think I'm fading. Next slide. I think we're almost there. So next slide is programs, professions, and roles. Next slide. So we have all of our I took away the word universal. Lucy, I heard you. Okay. To our social care professionals and programs and all of
Thank you.
Yeah, I listen. Okay, next slide. All right, so we have, again, this is nothing new here. Our SMEs correctly identify that you do not refer people to places in this domain. You bring the help to the person. So we are going to be submitting a request for concepts that make that clear. Next slide. And then, okay, that was language, and we are at, we're just a little over halfway through the call. We're going to pivot to incarceration status right now. And then I hope, again, hope Kwesi has, Milan is here. Hi. Okay, so we have a couple SMEs on the call. Thank you so much. And we're grateful you're here. Again, I really want to make sure that when we have subject matter experts on the call, we center them for any answers, because my only job is to represent their wisdom. So if we have questions, given that we do have SMEs on the call, I will defer those questions to them. Next slide. These are amazing subject matter experts. Again, just incredibly grateful for all of these wise and thoughtful and ethical humans who've guided our work. And just want to note that Milan and Radha have been involved from the beginning and really kicked off this domain and so very, very grateful for their early assistance in gathering all these SMEs, because their expertise and wisdom and thoughtfulness is woven throughout. Next slide. All right, next slide. So again, not a ton of updates here. These concepts were made pretty stable. We are working on good definitions with some of our concepts, but these concepts are fairly stable. These are the currently incarcerated concepts. When we actually build them into SNOMED, the currently might drop off. So we're kind of working in our sandbox on options there. We have a lot of work we're doing right now to come to consensus on the once you're in community concepts, and those are on the next slide. Next slide. So this is a concept that I'm sorry, we're not quite into the in-community. So one of our use cases for this is the best in practice work of supporting individuals who are currently incarcerated and re-entering in community, and the work within states supported by waivers to support that, especially given the inequity of previous lack of healthcare coverage. And so one of the concepts that we have in development is incarcerated and expected release within 90 days, which is part of that like pre-release planning phase. Again, evidenced in the literature. So that's something that has not changed since we were last here, but that's the why of why it exists. Next slide. Again, when we think about the recently incarcerated and reentry subtypes and what it means to be in community, we really are trying to focus on that process of reentering rather than the history of incarceration to limit the potential for bias, and focusing on key timeframes within that reentry process. Next slide. I really want to thank our amazing subject matter experts for leaning in to some revised definitions. So just to throw things out there, we had a working definition, but the revised definition really leans into the process element. Again, thank you, Kwesi, for putting that out there. And we're working on this in our SME groups. Again, the concepts of the reentry concepts is our primary focus right now, to work on ensuring the sensitivity and thoughtfulness that we're having regarding representing reentry is represented well in those concepts. They might change in the next 2 weeks, but noting that this is really what we're leaning into in right now is trying to make sure that there's consensus between our subject matter experts on how to represent these concepts well. This is where they stand right now, but we have a meeting tomorrow and there's more to come. Next slide. And again, the same thing. So we have both adult facility and juvenile facility concepts. One of the things that, the tricky things that come up is like how to represent the special risk of when juveniles have been incarcerated in adult facilities. And again, all these concepts are getting worked on very, very intently, just on these concepts, focused within a special sandbox that they're working on together. Next slide. Inclusion of duration, because it represents critical windows of acuity and risk. Rob, Kwesi, Milan, do you want to talk about the duration elements and why we feel like it's important to represent them, and how the 2 weeks, 3 months, and 12 months are supported by the literature?
Sure. And Kwesi, definitely feel free to hop in. Yeah, so the highest, just from prior studies that have looked at reentry and health risks during reentry, the highest risk is during like immediately post-incarceration, so those first 2 weeks. Particularly because of the ways that our medical systems and carceral healthcare systems are structured, with health insurance, not covering carceral settings. So during those first 2 weeks, particularly for not even just for people with substance use disorders, but for people with substance use disorders, they're during incarceration, they've lost tolerance for substances. And so upon returning to the community, and for those who resume substance use, that can be a high risk period, especially during those first few weeks. But even studies have also shown that other health conditions, for example, people with cardiovascular conditions, people with cancer, their health can stabilize during the immediate 2-week period. So that's why we emphasize 2 weeks, because there have been several studies that have specifically looked at the first month, like the weeks within the first month, and then have looked further out at like up to a year post incarceration. So I don't know if that answers question.
And can you also talk about why we're not why after 12 months, we are no longer focusing on documenting reentry and letting that sunset?
Yeah, so we really don't want to create just recognizing within healthcare there unfortunately are still providers and staff that stigmatize patients who have a history of incarceration. And so we really don't want just the record of them having been incarcerated to live with them beyond the period of a year when the literature shows that the health effects of incarceration absolutely can persist beyond a year, but are not as acute after that window. And so we really just want to be careful not to create opportunities for healthcare to stigmatize patients.
Yeah,
One of the
can I just make one point about this? So that all makes sense, and I'm sure that there's been some discussions with some at CT about the fact that you're including these durations, but so my question is, don't we also need a concept that just represents the idea of reentry from a juvenile facility, where the timing could be, say, you would be able to say, well, in a month, 1 month ago, right? So the problem with the what only specifying these is that you can't then specify reentry at some other interval, right? I mean, I understand the importance of these distinctions because they have clinical significance, but you then, if somebody comes in and you say, well, they re-entered, but it's been a month, you can't say it.
Yeah,
That's
and
not good. So we
yeah,
need
so
to be able to support that also.
I may let Sarah or
We've been working on, so Rob, we have been working with SNOMED early on modeling these, and this one of the questions that came up. We actually haven't I don't think the question of the exclusivity, because the thought that what John's been raising regarding is just like how you determine that it's exactly this, but I actually don't know if he's been discussing the fact that it would have to be exactly 3 months, because that's certainly the within is supposed to be including everything lesser. But
Well, that would also include 2 weeks too, which is,
exactly.
I mean, I get the fact that someone will we want someone to pick one of these when they want to communicate this, right? I want to communicate that a situation where the patient is, whoever, is in a phase of their post-detention life, that the risks fall into this category versus another category. And so picking one of these very explicit things has use. And I am pretty confident that SNOMED will say, if they say it's, we will support the idea of creating these context-laden codes, then there needs to be a code that is not context-laden, that we need to also make available so that people will be able to say something in addition, or when they can't say one of these things. That's still important, I think. I mean, I'm presuming, because I'm really worried when we have these kinds of very narrow bands that we don't let people say something more general. I think what you're saying is look, after 12 weeks, it doesn't matter. So we're not going to capture, or sorry, 12 months, we're not going to capture anything. And if it's within 12 months, but not 3 months, I'm going to pick this one. If it's been within 3 months, by not 2 weeks, I'm gonna pick this one, and if it's within 2 weeks, I'm gonna pick this one. If that's the intent, then okay, I still think you're gonna probably get one that's a general one.
Yeah, we
But
are.
we need to be clear about the wording of them then.
Thank you so much. And we are working with John. I want to leave, if I can, these are all in process right now.
Okay, sorry to
No,
disrupt
it's
you, but I
very
just,
important. No, it's very important. And we have a plan call tomorrow regarding this. And I just want to not talk about the SNOMED modeling at this time, even though it's very important, Rob. I hadn't even thought of that question yet. So, and I think it's really helpful for our SMEs to think through because they are very, very thoughtful regarding wording. But we sent, for the first time ever, I sent an early ping to John. Right. And so, so again, we're all really, really, I think that your thought you've raised is really important. Right.
Yeah, I want to, if I can, Rob, echo your sentiment. Your awareness and thoughtfulness in the present moment highlights the sensitivity that we're all bringing to the discussion and the work. And attempting to create an opportunity for a thoughtful practitioner, clinician to highlight other areas of the continuum of care is also in process of what we're offering as we're writing. Mm-hmm. So I want to offer that we're having discussions around a both and versus a one only.
Mm-hmm. Thank you, Kwesi.
Is that helpful, Rob? So we're not trying to box the.
Yes, it is, and I get it, and I'm not surprised that you're being thoughtful about it. So I'm what struck me is just a pure terminologic concern, and I'm glad you're addressing it, and I'm not concerned.
And again, I want to echo the appreciation of your awareness. Oftentimes we have conversations this way, maybe in other areas, at least in my experience, in other areas with providers who would not be reflective and thoughtful and intentional in the way that you are. So I just want to appreciate your bringing your voice into the space and to highlight how we might be reflective as well. So thank you.
Thank you, everyone. And again, Rob is reiterating that's a really important point that we had not thought about yet. So that's a level of nuance that we really appreciate. And Lucy?
I think Rob's comments were really quite significant, and I really appreciate the conversation about them. I'm just wondering how these time intervals are determined. Is this self-report? I was released within the last 2 weeks or does this have to be documented somehow? How are these intervals going to be determined for recording purposes?
Yeah, so clinically, providers find out in a few different ways, depending on how, for providers that have established relationships with their local carceral facilities, or some community healthcare providers also have contracts with their local carceral facilities. And so those are kind of the most ideal situations. For example, I work in a setting where we work closely with our local state prison. And so I receive report of individuals that are about to be released. I know what their release dates are. I'm able to meet with them before they leave. That's kind of more the exception than the rule. So most community-based providers are finding out directly from their patients. So when they're meeting with their patient may say, hey, I was, recently released from the local jail or local prison. And so it would be on the provider to ask how long they've been in the community. If some patients will volunteer that. There are also some community-based providers that, or some carceral facilities are better than others at sending medical records. Again, that's not really the standard across carceral facilities. So there's definitely a mix. We don't unfortunately have kind of standards that our carceral facilities follow. with transitions of care. The hope is with states that have the 1115 waivers, that there will be more of these established care coordination relationships where providers will then have information, medical information about patients prior to release. But there are only 28 states that have requested these waivers, so there, are still many states that won't have the push for developing these care coordination relationships.
I guess if I'm a provider, which I'm not, and maybe Rob could actually follow up, if I am aware that the first 2 weeks have some acute risks that I really need to understand, and ditto for the first 3 months or even for the first year, and my source of information is a person who may or may not remember clearly, care very much. I'm just wondering if there's clinical distinctions to be made within these bands. What is the best way to be sure as a provider that you're getting the information that you need to respond to the clinical understanding within these bands? Is that clear?
If I may, Lucy, I'm hearing you, and I want to also acknowledge, let's see, Matt, yes to your question in the chat. And the second piece would be to Jonathan, and which may answer your question, Lucy, and to support what Milan just offered. Probation and parole, depending on how, in what state, what county sometimes, or what town, the case management that's done for the individual when they leave a carceral space, how that information is transferred to the providing space, often there's a gap. It's very rare that it's very fluid. From a patient-centered care perspective, we would want to offer that the literature gives us these intervals for us to work through, and we're also centering the patient, their experience and their voice. If they tell me that they have been released from or are in transition from a juvenile detention facility to a home, let's say, what they provide me is their narrative. I'm going to hold their narrative. What I'm not going to do is suggest that their narrative is not clear or does not validate their experience based upon a rubric that I may have. I want to hear what they have to say and hold them in care primary. What the literature offers us is that these windows offers us a level of acuity. And to Rob's earlier point, we do want to offer that there can be a window of any time in which their acuity may be higher or lower, or they may need care. So I don't know that it's, I'm not hearing that it's a question of whether or not the human being, what they're offering, their narrative is true or untrue. It is their narrative in the present moment of which we are providing the care. And from that, we're providing a way for us to respond to that narrative.
That's very helpful, and I'm anticipating providers who really want to be useful in the re-entry interlude are maybe going to need to think hard about how to reconcile the narrative that they hear, which is basic, primary, and must be respected, with their understanding of risks within certain time periods. There's going to be, I would anticipate, work is going to be needed to ultimately provide the best response based on the narrative, enriched by understanding of risks by time period. Thank you.
Agreed, Lucy. And we can use kind of a best practice or an evidence-based practice of how over the course of 20 to 25 years, how we have nuance around HIV and AIDS patients is a similar question. We have to partner with not just the provider, we have to partner with how we understand in the information which we educate ourselves on, and how we develop a language and a communication style that helps us process the need of the human being who is in the role of the patient. That's important, and maybe not for the necessary frame of what we're doing right now. However, that's something we've all been discussing around what is the education and the experiential learning that's required for this nuance.
Yeah.
If that doesn't happen, the University of Rochester, where I'm at, we created a health and incarceration pathway just for that purpose, to begin educating the nuance for medical students and residents in this area, so that when they get to the code, they have the reflective practice of what does this mean for myself, and what am I experiencing, and what my own biases may be coming up with, or how do I attend to that feeling and also attend to the narrative of the human being, which is the most important piece of information I have. Our hope is that the code motivates us to care, motivates to seek support and resource. That would be the hope or the ultimate goal of what we're attempting to do. So it's a yes and.
That's terrific. Thank you for elaborating on that. And I'm hoping there's someone in this call who will call Robert Wood Johnson and say, time for you to invest $500,000 to take the Rochester learnings and spread them around. Thank you.
Thank you, Lucy, always.
Dennis, any other thoughts? Again, thank you for our subject matter experts for being so thoughtful, ethical.
Yeah, I just wanted to touch on this. I can see benefits and detriments to the 2 weeks, 3 months, and 12 months. But as so many of us know, just trying to coordinate when the individual's inside and being released, ideally they would be there in the past, there's a connection within the next 2 weeks. It all depends on where they're at. I mean, it could be a pregnant woman and, young pregnant woman. And so there might be a higher possibility of her receiving an appointment rather than somebody who is hoping to get involved with mental health and has not been before, right? So a lot of that, when they're actually seen, is another story. I just want to mention that you mentioned the 28 states. I'm one of the states, Washington State. We were early in working on some of this, and our county has just invested some money, and I'm one of, I think, 3 or 4 lived experience individuals where we're going to have a 3-day convening at the end of January on how we can tackle this. There will be a method that will be developed in the year afterwards. The 3-day convening is how to inform and find out the best practices, what's being done, where the gaps are, with all the experts in the field, basically. Just few lived experience people, but people that really understand the gaps. And then it'll be fairly good size convening. And then for the next year, they're developing a method how to capture these individuals and ensure that they're getting the care afterwards. So it's called the Jailhouse Services work group I'm on right now. But as it proceeds, I'll let you know. I'm pretty excited about it.
Janice,
Thank
I'm
you, Janice, for
so,
offering.
oh,
That's
sorry.
a wonderful sharing, and however, as another person with lived experience can be supportive to your effort, please share out with the group, because the more we hear and understand, the more we can support. I'm a big fan of yielding. When someone's doing something that works real well, we don't got to bend. We can just be cool with what you're doing.
Right.
It's not ain't that hard.
Yeah, we're going to ask for speakers and things too. And, you're somebody, I don't know if they just want local, but I'll find that out. But I think we're on LinkedIn. So, and by the way, I'm coming to University of Rochester on December 3rd. So presenting.
Oh yeah, I know that. Yeah, I heard about
Yeah, we'll be in contact. Okay. All right. Take care. Thank you.
I'm so happy to hear that they're centering lived experience in Washington. I really hope that other states do that. I'm in here in New Hampshire, they're not doing a great job of that, and really, really hoping that my state does. But that just makes me so happy to hear that your state is getting that right.
They've been doing it. It could always be better. And they reach out to Healthcare for the Homeless too. That was a group where they looked for individuals that have the lived experience, right? Because to deal with some of the continuity of health and, the other social determinants of health. So, it's centering it, but there's not going to be a lot of lived experience at the event. So, that's, I'll update you on that.
you, everyone. This has been a lovely conversation. This means now this conversation, this topic gets me really emotional. All right. Know that I really want to just honor the fact that the really thoughtful conversation we've had right now is why the SMEs are, we pulled, again, as I mentioned, all of these concepts into a special space to really just talk about them uniquely and ensure that that they are able to bring their wisdom and ethics to bear in the right way. And your thoughtfulness over the course of this time will help. And again, that's the work, the primary work of the next couple weeks, is to lean into these with care. All right, I'm going to try to keep us going. Okay, if we can go, there were some questions on the community supervision concepts, so I think that's our next slide. Oh yeah, so I wanted to, sorry, before we get there, we presented on solitary confinement last meeting, but again, out of a real deeply ethical, thoughtful, careful way, we again are pulling it into the sandbox of this special space to talk about these concepts, because we had some really interesting conversations with our subject matter experts regarding how carceral facilities get around regulations for solitary by implementation of forced lockdowns. And our SMEs really wanted to, pull all that wisdom together into again, the special sandbox on these kind of critical sensitive concepts. So we'll come back with those very shortly. Again, I don't know if our SMEs want to say anything regarding this concept, but more to come here.
Sarah, I have always used the concept sandbox with a slightly derogatory implication. So I'm wondering if there's a better word.
We can,
Is there a better word for what you want to do here?
Yeah,
this is not playful at all.
I know. And I hear you. I think this is like by saying it that way here. Yeah, we can.
Okay.
Okay. I think. Okay, next slide. I do want to get to this. So we were talking about concepts of community supervision earlier. Tom, I believe you had a question regarding that. It is represented here. We also have our concepts for treatment courts and specialty courts we're leaning into, supported by the evidence and best practices of the group All Rise. So those are concepts we'll be developing. Next slide. And then we do have our legal needs concepts on the next slide. Noting that we haven't addressed the legal needs affecting voting. Lucy, that you raised an earlier meeting, but these are the ones that we have so far. And we are thinking about the wording here. In the press, we use the word affecting, but in the past we've used the word limiting. And so this might be a subtle change. When we went back and looked at precedent, we used limiting just like we use in the definition. So again, these are kind of our last end-to-end review refinements that we might make before we bring them back. And again, voting is something that we've, it's on the SME master list to assess. We just haven't gotten to it yet. And then we did finish our program review, or at least I think we mostly finished it. We have 2 more. Next slide. It's no update here. We are not supporting. There is no evidence-based method of person-centered assessment of histories of incarceration. I do want to note already our subject matter experts are, proposing and leading research studies to gather firsthand information on person-centered perspectives of being screened for histories of incarceration. So the analysis of the existing instruments and the paucity of data is already yielding future studies on this concept, not necessarily on validation of specific instruments, but about patient perspectives and person perspectives on screening, and more to come there. Next slide. Okay, and next slide, goals. A lot of work in the goals space. And again, I want to just honor some of the thinking that's come in through. So we had a great conversation last meeting regarding goals that align with self-efficacy and affirmation. Kwesi led us in a reflection on opportunities to identify roles, relationships, responsibility, and resources as we look at goal statements. There are a lot of existing goal statements that exist already, aligned with literature such as self-efficacy literature and Bandura and otherwise, because they're used extensively in the documentation of nursing in inpatient settings and outpatient settings. But you'll see on the next slides everything that's in the hopper that already exists. Next slide. So these are concepts that already exist in the literature, and again, not to be the complete. We're not at completeness yet, but we pulled them from our prior domains and from SNOMED concepts that already exist, aligned with the concepts our subject matter experts were raising. And again, for anyone who we talked at the beginning of the call, our hope to lean into protective factors in 2025. Again, you'll see, self-efficacy is a really, really critical protective factor as well. So when we do that work, there's some literature there as well. And again, you can see there's a hopefulness concept in here, and then there's the vocational concepts. Again, more to come. The SMEs are identifying all kinds of opportunities for things that are not here. I think this is on the next slide, including specific concepts for the reentry program. Again, this is actually another slide on existing concepts within SNOMED that align with previous domains. And next slide. I guess it was it, but there's more coming. There's a few concepts the SMEs are reviewing in the SME master list that are, we really want to help them in supporting and identifying the concepts that matter. We always do this with each domain, and this is really important here as well. Next slide. Okay, next slide. This is just a general. Lucy, yes?
Yeah, Sarah, if you could go back a slide or two. Yeah, that's fine. Please forgive this question. It's going to sound incredibly naive and distant, but I read a lot about recidivism. Someone is released, they don't have adequate anything, and then they're back. So I'm wondering if there's a goal statement that could or should capture, I don't want to go back, and I feel like I'm not going to, or I'm making sure that that isn't going to happen, or I don't know, something to that effect. Is that meaningful from a person-centered perspective, a person who is in reentry? That's a question.
First, Lucy, there's this is not your question is not naive in any way. In my experience, an individual or individuals who are in this transitional period of their life may and may not want to stay out. There are many people who actually do not want to be in the community. They actually want to thrive within the carceral space. So I'm mindful of the aspiration to stay out. There are many ways that we can capture that from a motivation to change standpoint. And the literature and some of the current codes actually offer a motivation to change framework. And in that motivation to change framework, I think Matt kind of talks about that from a clinical psychiatric lens or a psychological lens, that a motivation to change can capture where the human being is in their belief and action statements and systems to move towards that level where they will actualize their ability to stay or do what it is they want to do.
That sounds really helpful. Motivation to change.
Mhm.
There may not be that motivation. And if someone thinks there should be, then we get into the dynamic of who's going to decide what I want my future to be. So we don't have to go there, but it's very helpful for me to hear that there is a motivation to change concept and that maybe it will find its way somehow into goal setting. Thanks very much.
I just want to add, it usually is somewhere, someplace, but not always. But as Kwasi had mentioned, some individuals feel very unsafe on the outside, and they do feel safer on the inside. And just to be honest, where I live in this central area in Seattle, a friend of mine has lost 2 sons to gun violence, who both were incarcerated at one point in time. And it's just really hard, right? And so just coming back and being in the same environment can lead to a lot of problems. So even if there's goals and we had mentors with both of them, things happen.
Thank you, Dennis. I want to pull forward also what
Milan has made a wonderful statement in the chat about
Yeah.
this.
And that's partly because what Milan did well is talk about how we have been thinking about the goals in our SME meetings, of course, because she's one of our SMEs. Right, like what do you identify as like needing and heading to right now, right? And the specific resources therein. So this is partly why we've pulled in all these goals from both prior domains, but also leaning uniquely into the, into the protective factors and asset building that Kwasi was speaking to as well. Again, thank you, all of you. We're almost at time.
The question that you asked, Tom, is valuable here as well. However, one of the challenges with tracking that data is that there can become an overt bias in the frequency, duration, and time in which an individual experiences the carceral space for multiple reasons within that area. Similarly, think of, or I would offer to consider, in an ED when you hear a staff or a group of clinicians say, oh, that's a frequent flyer.
Mm-hmm.
That frequent flyer status sets up a continuum of care for that individual. And we may not know what that means for that individual of why they experience situations on a regular basis. And what that also can do is sometimes a person can be lumped into that quote unquote frequent flyer. And it might be their first time encountering you as a clinician. And then the over bias of the treatment team is already subsumed in the frequent flyer model. So what we're trying to hope for is that the data tracking of frequency, duration, and time can be thought through in other ways. If we keep it in as a part of the record, the data is kind of clear around if a person is experiencing SUD around, let's say, alcohol, they become a frequent flyer and their treatment can be subsumed under that frequent flyer status. And there can be other multiple reasons for why that person is experiencing you as a provider at this point in time.
Thank you. That's so informative.
We are at time, we're very close to it. I do want to note that some of the things in the chat, I think we have, like sleeping safely is one of our, I think Lucy, you were there in homelessness when we developed that concept from way back to 2020. Before we go, I just want to note that we did not get to all of the new programs. There's a pretty important one. If we can just, I hate to push us through. This is not new, this is not new, this is not new, this is not new, but I want to note, we'll go back, that we do have one new concept and program, which we're elevating again, like just thinking about Kwesi's model and the work he's doing. And someone mentioned wanting to tell, like from your design, Kwesi, to Robert Wood Johnson. We did lean in, we were talking about mentoring and peer support and where that happens at a previous call. We do have forensic peer support specialists as an existing program. And then we wanted to also center this, what the program, this means referenced in the chat during that meeting, which is the model of transitions clinics. Even if it's aspirational, it's best in class and evidence-based aspirational. So we pull that forward, and you'll see that in the master on Tuesday. Incredibly powerful meeting as usual. Thank you all for your perspective. A few updates to the master that you'll see. And again, I want to leave space for the fact that those concepts that we mentioned that we were leaning into, the SMEs might make changes before it's posted on Tuesday, and will reflect their wisdom in there, because they are our ethical leads in all this work. And again, thanks so much for all the thoughtfulness today. Any other final thoughts before we go? Yes, Dulas.
Thank you, Sarah. This is so leading edge.
Our SMEs are definitely on the forefront of really important things, and so very grateful to have their wisdom brought to bear. It's my honor always to spend time with them. So thank
You aren't going to cry all after this, are you?
I know.
Are you dry? Are we leaving you dry?
I know. My SMEs.
It's hard.
Milana Rhoda can testify, and I think Kwesi's seen me cry too. That is something that happens regularly. So thank you all. Thank you, SMEs. And we will see our SMEs tomorrow, and then we will see you all in 2 weeks, which is our final end-to-end review. I'm very, very grateful for all of your wisdom, and have a good Halloween.